I developed a program on the models of dental practice in large measure to help the younger dentists who are entering into practice and feel that they have to enter into insurance contracts that they perhaps don't understand as well as they would like, and they're not sure whether they make economic sense or not, but they feel compelled because they need access to patients. To me, there are two basic types of dental insurance contracts. There's the PPO type, which stands for Preferred Provider Organization. That is a discount program, in simple terms, where you are trading an agreement to do dentistry at a discount for access to a pool of patients. And if you have a government-sponsored program such as Denti-Cal, that is a type of PPO. The large providers such as Delta Dental, MetLife, Cigna, Humana, they all have reduced fee schedules that have been put together by what are called actuaries. Those are people that analyze data and decide how can a plan be put together based upon usage so it will make economic sense for the insurance company that is underwriting the plan. And that is far and away the most common type of insurance in dentistry. HMOs, health maintenance organizations, are an offshoot of medicine. HMO started in medicine in 1977. It was a new model where the practitioner would agree to take care of a pool of patients for a specific amount of money per month, take care of all of their needs for that particular amount of money, and the incentive was the opposite of a PPO. Within a PPO, the financial incentive is to do lots of procedures, to provide lots of care. In an HMO, the incentive is just the opposite. It's to provide as little care as possible. Now, assuming that integrity with practitioners is a constant, the economic incentives do have an effect on the behavior of the practitioner, and it is imperative that the fee schedule that's in a PPO plan is commensurate with the way the dentist is going to practice and with the value system that the dentist has. So I created a simple model system to help dentists understand, based upon the way that they choose to practice, maybe more importantly the way they feel compelled to practice, to see if they can set things up economically so they can have a reasonable profit margin operating under the umbrella of dental insurance. So the Model 1 practice in the state of California, to my knowledge, is the most common, and that's where about 1/3 of the patient care that's being provided in the practice is coming from insurance contracts. And typically that's going to be through one large contract with Delta Dental. The prototypical traditional fee-for-service dental practice in California, there is a Delta contract in place. About 1/3 of the patients are coming from Delta, and the other 2/3 of the patients are coming from cash-paying patients or from patients who have insurance that the dentist is not contracted with. If you have a typical fee schedule situation in an urban area, that is usually going to mean that 1/3 of the dentistry is coming from those PPO patients, but only about 25% of the revenue is going to come from that pool of patients, and that's because those patients are being treated at a discount. Most typically, you are going to have a staff that is going to allow your overall overhead, assuming efficiency with your overhead, to be at about the 70% level. You're going to be able to have a profit level of about 30% in that type of practice, assuming all other systems are operating efficiently. Model 2 practice is twice as much PPO activity. Very often it means more than one PPO, or it could be a practice that's in an urban area that's very close to where government workers are, for example, downtown Sacramento. Many government workers have insurance through a Delta plan, And it's possible that because of the large population of government workers or another industry that has a large Delta plan could drive a much larger percentage of the patients into the practice. But that Model 2 practice has about 2/3 of the patients under the umbrella of a PPO, and so a lot more of the dentistry is being done at a discount. So all things being the same, the dentist either has to do procedures at a faster rate or has to delegate more procedures to auxiliaries, and usually it's going to be the latter. And so a larger staff is necessary, a more highly trained staff is necessary, and because of those increased staff costs, the overhead of the practice will probably move to about the 75% level. Model 3 practice is 3/4 of the practice comes from insurance. Many Model 3 practices will have HMO plans mixed in with PPO plans, and it's not unusual for those practices to have staff costs that are high enough, and of course the increased supply costs that are going to go along with the greater volume of dentistry, where 80 to 85% of the revenue that comes into the practice is going to go to overhead. So those practices often operate on a 15 to 20% profit margin. Model 4 is the least common type of practice. Only about 10% of the practices in the state of California. That is the insurance independent practice. No insurance contracts at all. Now that doesn't mean that the practice doesn't take insurance and process insurance. Patients that come in with insurance that the dentist is not contracted with are processed. Those ancillary services are provided as a value-added service for patients, but very often those practices can operate at a 50 to 60% overhead level. It's not unusual for an insurance independent practice to have a profit level of 50% of the revenues that come into the practice. So the amount of dentistry that's done is much less. The trade-off is that since you're agreeing to take patients at a discount with insurance plans in order to access a pool of patients, if you are a Type 3 practice where most of your patients have insurance that you're contracted with, you have access to a large pool of patients, so you have lots of patients to work on, as opposed to a Model 4 practice where you have no insurance contracts, and so your pool of patients is smaller. In the end, I think for most dentists, it's how do they feel about the dentistry that they're doing, and how do they feel about their income. Doctors can be successful in any of the models, but the marketplace is forcing, I think, many dentists to feel like the model is choosing them rather than they're choosing the model. So it helps significantly for dentists to have an understanding of what the models are, so they have more knowledge, and they're going to be able to choose more carefully from that knowledge base.